My name's Paige Humble, and I'm the Chief Executive Officer of Lung Cancer Initiative. And it's just wonderful to see you all here this evening. We were just overjoyed with the interest in this session, and I think you're in for a treat with our speakers tonight. I just have a few announcements and notes before we turn it over to our speakers. First off, tonight would not be possible without our wonderful exhibitors. And I want to thank AstraZeneca, Bristol Myers Squibb, Amgen, Jazz, Takeda, Genentech, Lilly, and G1 Therapeutics for making tonight possible. And I want to invite you all to please stick around to the end to meet our exhibitors. There will be a drawing for a $50 Amazon gift card at the very end of the event, but you must be present to win. So please stay around to talk with our exhibitors. I want to tell you a little bit about our organization in case we're new to you. Our mission is to advance survivorship and provide support to those impacted by lung cancer through research, education, and access programs. And your one takeaway about LCI is that we have resources for you and your patients. We have gas cards, we have patient emergency funds, so we offer stipends to help with financial burden of a cancer diagnosis. We also fund lung cancer research. We do that with many of your institutions, and we're looking to partner with others as well. If you're wanting to get involved or you're wanting to give your patients a way to get involved, we have several events coming up that I want to make you aware of. Our Triangle Lunge Forward is coming up here in the Raleigh area on September the 24th, and it's a walk event, and it's a fun family celebration and a great way for people to get involved in the organization. Also, for our folks in the Triad, we have a 5K run coming up on October the 8th in Greensboro. It is also a very family-friendly event, and it's a wonderful way for folks to get involved in the Triad area. And then we also have our Evening of Hope Gala coming up on Saturday, November 5th, and that's in the Raleigh area. And again, a great way to network and also to meet people from all across the state who are a part of the lung cancer community. I want to also share that we will have time for questions this evening at the end of our presentations during our peer exchange portion of this meeting. So without further ado, it's my pleasure to turn it over to Dr. Neil Reddy with Duke Cancer Institute, who is also a member of Lung Cancer Initiative's Board of Directors and who leads our Scientific Advisory Committee. Dr. Reddy.
Well, good evening, and I'd like to thank the Lung Cancer Initiative for hosting this program. I'd like to thank all of our speakers and also all the participants. So this is an exciting time in lung cancer. There have been lots of advances in lung cancer screening, lung cancer diagnosis with evaluation of biomarkers in both tumor and in blood, advances in surgical techniques, radiation approaches, new molecular therapies for lung cancer with new targets coming along all the time, and not only immune therapy, but immune therapy combinations. So it's really hard to keep up now. I couldn't say that 20 years ago, but with all the data that's coming out, even as a lung cancer specialist, it's hard to keep up. So it's wonderful to be able to pull experts together to go over some of the most recent advances in our field. And tonight we're going to start with Dr. Mehta, a pulmonary doctor from UNC Rex. And then we also have Dr. Charles Shelton, a radiation oncologist from the Outer Banks. Dr. Andrea Oliver, a surgeon from ECU, who has just been called off to surgery. So we're not sure if we're going to see Dr. Oliver tonight. That's sort of the nature of the specialty. Dr. Hagstrom from Levine, a medical oncologist, will also be talking to us tonight. Dr. Patel from UNC. And of course, Dr. Jimmy Ruiz from Wake Forest. So I'd like to thank all of our speakers in advance. And now we'll be hearing from Dr. Mehta on some of the pulmonary aspects of treating lung cancer.
Thank you, Dr. Reddy. Appreciate that. Hopefully everybody can hear me. I'm going to screen share here. And hopefully this works. Okay, can you guys see that?
Yes.
All right, perfect. So I have lung cancer screening. I think this is near and dear to my heart. Anybody knows me, very passionate about it. This is, as of the last 10 years, have been kind of a big project of mine to keep educating and moving this forward. It's an update on lung cancer, but with lung cancer screening, it's important for me to provide some background information. How I hope you can, what you take out of this is able to answer questions that maybe your patients will have. And a lot of these questions are questions that my own patients have for me when I talk about lung cancer screening with them. I think it's important for us to understand the scope of the problem. So we'll talk about recommendations for screening. We'll review some of the literature. I'll try to be brief. I've done this before, but it's important for us to know where these recommendations come from. I'll talk about billing and coding requirements. There's been some new updates and changes to that. And then at the end, just a fun section on myths of lung cancer screening, which you'll get a lot of from patients, and hopefully you'll have an answer for it when you're approached. So kind of going over let's go over some of the evidence behind lung cancer screening. Lung cancer screening initially started with chest x-rays, sputums. They've been screening since the 60s. And why this is important is I still get patients who will say, well, why can't you just do a chest x-ray? There's a lot less radiation there. And this is kind of what I bring up, that we've done many studies since the 60s, 80s, and 2000, as early as the 2000s. And unfortunately, chest x-rays and sputum cytology has never shown any mortality benefit. And in fact, as I go through the data, I'll review and show you, in fact, CT scans have shown where it picks up missed nodules or malignancies that were not identified on a chest x-ray. So it was really the refinement of the CT scanner that allowed us to start doing some more elaborate screening scans. Some of these low dose scanners are high resolution single breath scanners and with a lot less radiation exposure. So this is one big question we get about lung cancer screening, and I think is important to understand ourselves. What is the difference in the CT scan from a regular CT scan to a low dose or a low radiation dose CT scan? For one, it's 1/10 of the total radiation given in order to do the scan. So the second question would be, well, is it good enough to identify lung cancer or nodules, masses? And in fact, you can see here, I got two images side by side. One is low dose radiation, one is regular dose. It's a lot lower radiation, but you can see that nodule on both very well. So it's able to pick up these nodules or masses that you identify in the lungs, but you can see some of the background tissue is degraded with the lower radiation dose. And that's why these have been so helpful in identifying these smaller nodules. So when asked, it's 1/10 of the dose of a regular CT scan. So once this CT scanner was produced, we started doing all types of studies with low dose CT scanning, looking for mortality benefit. Although we were not successful, most of these studies were underpowered. It wasn't really until two more recent studies, the Nelson study and then NLST, which I'll go over, is when we started seeing a lot of the mortality benefit as they were powered to see some benefit. And you can see that the sample sizes from the bottom unpowered studies, only a few thousand, versus the top around 53,000 for the NLST, and Nelson was around 16,000. This is where we started seeing some mortality benefit. So the first study that was published was an NLST study. A lot of you have heard about this at this point. This was a multi-center study, looked at 33 US medical centers, 53,000 participants, the age between 55 and 74, that's an important number to remember, 30 pack year history. Pack years are calculated by the number of packs you smoked times the number of years you've smoked them. So if you smoked 1 pack per day for 30 years, that's 30 pack years. And then if you're an active smoker or have quit within 15 years. And that was the requirement they used as their baseline. What they looked at was looking at low dose CT versus chest X-ray, and then they split the group in between those and noticed a significant relative reduction in those that were screened with a CT scan versus a chest X-ray. There was a nearly 20% fewer lung cancer deaths in those screened with CT scan versus chest X-ray, as several of these smaller nodules were missed on the X-ray. That's a 6.7% reduction in all-cause mortality. So what does that mean as a screening test? How many do we have to screen to save one cancer death? So number needed to screen to prevent one death. With lung cancer screening, that number is 320. That means you'd have to screen 320 people to save one cancer death. Relative to breast cancer screening, that's around 900 to 1900 folks would need to be screened, and then colonoscopies is 500. So you'd need a lot less folks to screen to save one cancer death with lung cancer screening. This was the second trial that was done, Nelson trial. Nelson trial was a European trial. Now, the interesting part here I want you to look at is the age cutoff. And that's going to be interesting as we talk about guidelines and age group here. 50 to 74. So they chose a much younger population, whereas NLST chose 55. They basically chose to do a lung cancer screening CT versus control, which is no screening or providers just do their usual screening. And with this, some of the take homes that I want you to get out of this was there was a very good compliance rate in terms of screening. A large portion of those folks screened on the participants in this study, 69%, found early stage cancer, stage 1, stage B, and that's going to be very important. Their all-cause or their mortality benefit here was 26% reduction in mortality when we used low-dose lung cancer screening CTs to help screen folks. So based on these studies, originally with the NLST, the U.S. Preventative Services Task Force created a solid recommendation, grade B, and you see the grading there, a strong recommendation for screening. The initial guidelines were based on the original NLST studies participants. So that's age between 55 and 80 and 30 pack years smoking, either active or have quit within 15 years, similar to the NLST trial. It was recently updated. We covered this last year at our meeting. In 2021, this guideline was updated. So these are the new guidelines, actually. So now you're screening patients that are 50 to 80, and you'll see that drop down to 50. And we'll talk about that a little bit, and we'll review some of the literature and brief why that number came about. And they reduced the total pack year to 20 from 30. Keeping that active smoking or less than 15 years as the third portion of that. So where did that change come from? Why did we change these new guidelines from 2013 to 2021? Well, it was largely based on the updated studies. They actually went back and looked at several randomized controlled trials, including that Nelson trial, which I showed you. And in Nelson, what they did was they showed that patients from 50 to 55 was at least 1/4 of the participants in the Nelson trial. And they had a 26% benefit in mortality as well. And so through empirical data, the decision to change it to 50 was made based on that updated 2018 Nelson trial. In addition to that, and I don't want to go into too much detail of all the studies because I know we have several talks laid up today, but there was several studies that looked at African-American or Black persons who were inadequately screened based on the previous 2013 data, as this was, where they looked at 48,000 smokers. They went back and used the 2013 guidelines and said only 17% of Black persons would have been screened based on the original 2013 guidelines versus 31%, almost twice as many white persons would have been screened based on that data. But unfortunately, in that same study, what they did was they looked at patients that were diagnosed with lung cancer, went back and said, well, had that person been screened, would they have met criteria? And only 32% of patients who were actually diagnosed with lung cancer would have been screened in the Black population versus 56% in the white population. And that made such a significant difference. So we were under screening even patients who had active lung cancer. And that was the same with stage 4 lung cancer, noticing that the median age was lower in the African-American population than the white population. And this was starting to bring the point that we were missing a gap of socioeconomic, race, and women based on the Nelson trial, which I didn't go into too much detail. But so the other thing they got from this is when you increase the screening when you reduce the screening age cutoff from 55 to 50, and you change the smoking pack year, you will actually increase the number of patients who are eligible for screening to 85%. More patients can be screened, largely affecting the Hispanic, African American, and women would be screened much more. So again, based on that data, it was basically based on the literature. They found that there would be a notable impact on the African American population and women who typically smoke less than men and are diagnosed with lung cancer. So those were some of the driving forces for changing the criteria. So I put this in here for lung cancer screening. Why is it important? And what did this data show with these reduction in overall mortality, but also the Nelson trial demonstrating a significant percent of the population that was screened being found in early stage cancer. When you look at this slide, what you see is staging from stage 1 to stage 4. And you have the difference between the cancer registry, a control group, and the screening arm. And as you see, the blue, significantly more evidence of lung cancers, the early stage in the screening arm. And it's the inverse. When you don't screen patients, most of them are found in stages 3 and 4. But if you do screen, majority of the patients are diagnosed in stage 1. That the dynamic shift that you're talking about. And with that said, that's basically the biggest tool we have to help improve survival rates. Those that are screened early, found cancer early, have a much higher chance of survival, flipping from a 5-year mortality anywhere between 3.5% to 5% to 85% survival if we find the cancer early and move on to surgery or more definitive treatment. So reimbursement, this is an important question. This is actually has some changes to it as well. So most of the criteria, you can see the age group in the slides. It's an old slide, but it provided all the information I needed. But remember that the criteria has changed now 50 to 70. Well, for CMS, it's 50. For private insurance, it's age 50 to 80. CMS still covers 50 to 77. But that's important now. And 20-pack year smoking, active smoking less than 15%. Some of the components, as you order lung cancer screening, you have to have some components to your order. You have to have the right age, the tobacco smoking history. They have to be clinically asymptomatic. That has to be documented that the patient's asymptomatic screening. And you have to have shared decision making. And I'm sure some of you have heard this. What does that include? It's either a face-to-face visit or even televisits, which would be billable, but it's a discussion of the risks, the benefits of lung cancer screening. It's a discussion regarding coverage and findings. So it provides that information to the patient so they're making informed decisions when getting screened. One of the big developments is CMS this year in February did approve and expanded their coverage to lung cancer screening with low-dose CT to include the new USPS task force guidelines, which is a huge thing for covering a large portion of these patients. If you look at the age group, a large portion of these patients is CMS, Medicaid, Medicare insured folks. Lastly, but very importantly, some of the things that need to be discussed is, when bringing up lung cancer screening with our patients, we really need to talk to them about, if you're screened and we do find something, are these patients willing to proceed with treatment options, surgical or non-surgical options? And those will be important. One of the questions we run into, even in our tumor board, is what if the patients had lung cancer in the past? When do you resume lung cancer screening? And that's usually more than around 5 years out of lung cancer treatment. We do resume surveillance screening scans for these patients who still meet criteria. So real quick, I'm kind of running over here, so I'm going to try to go through these pretty quick here. Myth, if I quit smoking, I am no longer at risk and don't need to undergo lung cancer screening. We know that based on the data I presented today, that's not true. You still would be eligible for screening even 15 years out from smoking. So it's important to make sure our patients understand, despite quitting, unless they've quit for more than 15 years, they should be screened, and there's a benefit to that. Lung cancer screening is still considered experimental and is not a standard of care. Since the publications, NLST and Nelson's trial, like I've said, they are now standard of care. We should be offering screening to all patients that meet this criteria, and they are all covered by CMS and most private insurers. Lung cancer screening has a high rate of false positives, leading to many unnecessary procedures. Now, as providers, we all know anytime you do screening, there's always going to be a rate or risk of false positives. Based on NLST's study, in the year one, there was 26%, 27%, and 15% respectively of false positive findings on this, whether it's a benign tumor or benign nodule. And Nelson had similar numbers, slightly lower. Looking at the data, very low risk of these false positive pickups on screenings leading to actual procedures. And I put the percentages there for you, but for time's sake, I'm going to skip that. But you could see that the percentage of actually going on to procedures was pretty low, or the risks of patients who underwent an unnecessary procedure was pretty low. The scans used in lung cancer screening expose you to dangerous radiation. I think I covered that. It's actually a fraction of a regular CT scan. You're getting 1/10 of the dose of radiation. Total life radiation dose and cancer risk from screening is pretty low, less than 0.05%. And again, these scans don't require contrast or dye when doing these scans. If lung cancer is found, it will be too late for effective treatment. Again, that's a great time to bring up that a large portion of the patients found in screening were early stage, around 70 to 75%, improving overall 5-year mortality in fight against lung cancer. This is just the summary slide. We've, I think, shown the lung cancer saves lives. There's some risks. You have to understand the risks and benefits of it. We're improving. Actually, that's incorrect. I'm sorry. Our North Carolina screening rate is 8% now, up from 6% last year. That still falls very short in terms of colon cancer screening, which is around 75%, and breast cancer screening with mammograms, which is around 74%. We're still far below those marks. And I just put this in here just so you guys keep the new guidelines in mind when seeing patients that need to be screened. Happy to answer any questions. Or I think we're saving questions till the end, right?
That's correct. Dr. Mehta, thank you very much. That was a great talk, and it emphasizes that we all need to work at improving our screening rate, both as advocates and as healthcare providers. So now we're going to have Dr. Shelton, our radiation oncologist on the panel, give us an update on advances in radiation for lung cancer.
So, Dr. Mehta, can you stop sharing and then I'll start sharing? Awesome. All right.
That should work. Yep, all yours.
Yep, got it. All right, so hopefully you guys are seeing my.
Yes.
Presentation. Okay, not my notes, but my actual slides, right?
Yes.
Okay, great. So I'm going to talk today and provide a community perspective on lung cancer while discussing the expanding role for radiation therapy. Being rural can mean being far away from care. In our case, you can see just how barriers are inherent to our geography. These are my disclosures. I have no conflicts. I do not have all the toys and the resources at our hospital that I'm going to show you today. But through network collaboration, patients within Eastern North Carolina do have increased access to all of them. And I do participate currently on a grant with UNC Lineberger to look at ways to reduce rural-related lung cancer disparity. I would also like to point out that this is a network coalition of hope and action, and lung cancer is the perfect cancer in which to highlight how leveraging a network can favorably change outcomes. So if you want to move the dial in lung cancer, or in cancer rather, lung cancer is a great place to start. Cancer is the #1 cause of mortality in North Carolina and likely in your area. Lung cancer is by far the #1 cause of cancer-related deaths. Remember the 80-20 rule. So lung cancer should be one of the vital few where we really need to focus on doing better, whether that's better screening, better timeliness to specialist care, better treatments, better collaboration, et cetera. And interestingly, rural disparity versus urban is actually a trump over all other causes of disparity for lung cancer mortality. It trumps all the ethnic groups altogether. So my goals today, I'm going to discuss the following topics in relation to radiotherapy and lung cancer from a community perspective. One, I'm going to talk about some of the new indications and expanded indications for radiation therapy. Two, some newer technologies and how we deal with this. Three, how we're seeing improved outcomes through expanded uses of radiotherapy in conjunction with and thanks to other therapies. And finally, number 4, I'm going to talk about the power of networking from the perspective of a small community hospital. So radiation therapy has a role in every stage of lung cancer. For stages 2 and 3, node positive, classically standard fractionated radiotherapy is used in conjunction with chemotherapy, followed by immunotherapy in inoperable stages of non-small cell lung cancer. Pre-op chemoradiation is used in some 3A with minimal nodal burden. Radiotherapy is classically used with chemotherapy in limited stage small cell and as consolidation in extensive stage disease. And then prophylactic cranioradiation is sort of in evolution right now. Some folks are looking at omitting it, but it's still considered as a portion of therapy for small cell. What we are finding is that Imrt as a technology is proving better than 3-dimensional conformal therapy in most cases of definitive treatment. For earlier stage cancer, we're seeing increasing use of radiotherapy as primary treatment for patients who are not surgical candidates. SBRT, which stands for stereotactic body radiotherapy, uses very focused, small beams of radiation to treat very precisely, typically in 1 to 5 treatments. As we find earlier stages through screening, as Dr. Mehta alluded to, SBRT is increasingly being utilized. And for stage 4, we're seeing an increasing use of short course radiotherapy in the setting of oligometastatic disease, which means limited metastatic disease. We often treat limited metastases with aggressive SBRT, and we then treat the primary with curative therapy as well. We're pleased to have new generation linear accelerators for radiation therapy regionally. They allow more precise treatment delivery and less time for completion of therapy. A majority of community facilities treating cancer use this type of machine with the latest bells and whistles. Typically, these machines are coupled with imagers, including a high-quality CT picture that's generated of the patient's internal anatomy at the time of treatment, which can help guide the therapy and as well can help monitor the response to treatment. This is an example of a short course Imrt plan used on a patient, which is more conformal historically than what we've done with older technologies, as seen here. I'm not sure if you guys can see with the pointer here, but this is very tightly wrapped around this patient's tumor, and you can see that it's also avoiding many of the critical structures like the heart, the spine, and much of the normal lung. This technology allows less treatments, better dose delivery, and less toxicity by sparing more of the normal nearby organs. This gentleman was not operable and was able to be treated in 15 fractions instead of the classic 30 to 33 treatments. This technology is already available at each of our community sites in Eastern North Carolina, and these LINACs could further be modified to allow SBRT for even shorter treatments. I do not have one of these on the beach. This is a $7 million tool used for brain treatments only, but we are lucky to have access to a Gamma Knife unit in Eastern North Carolina. Aggressive treatment of oligometastatic lung cancer is an area that really leverages better radiotherapy technology. This before and after picture with an MRI of the brain shows how a solitary brain metastasis can be removed essentially with high precision radiation therapy using a single focal treatment, and correspondingly we can avoid toxicity to the rest of the brain that we would have seen with older techniques like whole brain radiation therapy or craniotomy. In this case, we used our Gamma Knife at the East Carolina University facility in Greenville. Better technology like this allows shorter treatments between immunotherapy and chemotherapy to achieve local control. This also potentially helps induce an immune response, as well as improving quality of life and perhaps disease-free intervals with less interruptions of systemic treatment. So let's talk about some of the newer technology uses. Image registration technology is now the standard. This allows us to fuse high-quality diagnostic images like PET and MRI to aid in radiotherapy planning, which is traditionally CT-based. This encourages us as radiation therapists to treat involved nodal areas as opposed to elective nodal areas, which can lead to potentially dose escalation and or volume reduction. Anytime you can treat a smaller volume, that's good. Breathing motion can also be better accounted for. This also allows for smaller volumes that can be treated. All of this allows less treatments of radiotherapy, which we call fractions, with higher biologic effective dose. So the typical example I use is in the old days, we would have treated 35 fractions over 7 weeks, whereas now for the same stage of early lung cancer, we can give 3 to 5 sessions of SBRT over 1 to 2 weeks. Less can be more. With retreatment of multiple areas in the lung, as well as elsewhere, we're now also allowing more options for control of disease. And this is becoming increasingly common in our experience. A new term, not just oligometastatic disease, but oligoprogression, is something that we refer to as limited progression while patients are on systemic treatment. And this is an evolving concept where we will sometimes consider a short course of radiotherapy to the site of progression so that there is no change required in systemic treatments. And there's some also techniques that we can avoid some of the areas in the brain that control memory. There's so-called hippocampal avoidance, which we do consider in prophylactic cranial radiation for small cell. This helps minimize cognitive loss as a consequence of therapy. This is a picture of a CyberKnife Accuray machine that allows us to accurately track and treat lung cancer and deliver very high doses to very small areas in a few treatments, typically 1 to 8. This machine looks and acts like a robot. In fact, I call this the robot for radiation. We have our own robot toys as well as our surgeon friends. And we commonly recommend this for early stage lung cancer and for aggressive treatment of oligometastatic disease. This is a $6 million robot and dedicated solely to SBRT use. This ability to network to access better technology and radiation has really helped us rurally. This is a lady with 2 synchronous cancers whom I treated locally over 6 to 7 weeks for her stage 3 anal cancer with standard chemoradiation, as we also treated her stage 1 lung cancer with 5-fraction SBRT at ECU. Pre and post imaging here shows a very nice response to the treatment, and this lesion eventually disappeared. What about protons? NCC guidelines do mention the use of proton therapy as another method of delivering precise radiotherapy to the tumor while minimizing doses to the normal structures. Where we live, we border Virginia, and we do have access to a proton facility within a 1.5-hour drive. But in our experience, proton therapy is better than conventional 3D conformal, but not better than the current Imrt or VMAT techniques that we use for thoracic disease. It is significantly more expensive, and patients cannot typically travel daily for this type of radiation. In fact, over the last 9 years that I've been here, we've had 0 thoracic patients able to get it in our area. Having said that, if you got this tool in your yard, Dr. Hagstrom, use it. This baby is a bargain price of $69 million with the Gamma Knife included that will be coming to Charlotte in 2023. And this would be part of a new RT facility at Atrium Health. So what about improved outcomes? This is a new norm. With the addition of better systemic treatment, patients enjoy longer survival where the benefits of local therapy can now be seen. With the integration of SBRT regionally, we now have safe options for patients who have limited pulmonary function, who may be inoperable, but they still can be cured radiosurgically with far fewer treatments than historically. And with retreatments possible, we now can be aggressive with oligometastatic cancer with ablative doses of radiation rather than the palliative doses that we used historically. This can improve quality of life. It might improve disease-free survival and potentially overall survival. A recent update of the pivotal trial, this pivotal trial in 2022, the Pacific trial, showed continued improvements from overall survival for late stage 3 lung cancer. Immune therapy was really the home run in this trial, but you have to start it. And ideally, you have to complete the immunotherapy to see the benefit. We found that we're able to start and complete planned immunotherapy when we use Imrt for lung cancer due to the lower incidence of radiation pneumonitis. This is a side effect that comes from too much lung being radiated. In our experience, Imrt use reduces the incidence of radiation pneumonitis 50 to 60% over 3D conformal radiotherapy. Remember, in the Pacific trial, patients were excluded from immunotherapy if they had radiation pneumonitis that was unresolved following chemoreds. So I want to talk briefly about normal tissue constraints. This is something you don't hear talked about much, but it's one of the advances in our field that really allows us a lot of science and improvement. This is the ability to predict tissue injury and/or recovery based on the science of normal tissue dose constraints and tolerances. We know exactly what volumes of lung can tolerate low doses of radiotherapy. We know what volumes can tolerate high doses of radiotherapy. We know how much we can push normal organs through the benefit of collaboration, clinical trials, for example, the RTOG, CALGB, Quantec data. And this really, I think, is the most complex part of radiotherapy planning, is understanding these constraints while figuring out ways to achieve curative doses of radiotherapy while respecting these limits. This is an example of what we call a dose volume histogram, and it looks like a lot, but I'm just going to go through it quickly. So in essence, this shows how much the anatomy in the area we're treating gets in terms of doses, the maximum dose, the minimum dose of radiation, what's the average dose to that particular organ. It shows every organ as a function of the dose. The x-axis shows increasing dose, and the y-axis shows increasing percentage of that organ getting that dose. The ideal scenario is you have all your normal organs over here getting low doses of radiation therapy, 1,000 centigrade, maybe 2,000 centigrade, while on the other side, you have your targets getting the maximum prescribed dose of radiotherapy. This difference in doses is known as the therapeutic index, and new technology in radiotherapy is making dose sparing better, which widens the therapeutic index in favor of more radiation therapy. So let me talk about the power of a network, and this has really helped us rurally in North Carolina. With a network of shared resources and a model of collaboration, we're increasing access to better care for a rural population. We have access to better diagnostic services for lung cancer, including specialty trained radiologists, pulmonologists, thoracic surgeons. Thank you, Dr. Oliver, who hopefully joins us later tonight, and other specialty trained providers, as well as expanded and better radiotherapy services. In Eastern North Carolina, we're blessed to have a robust prospective peer-to-peer radiotherapy review process. As radiation oncologists, through regional collaboration with faculty at ECU and 5 community hospitals, we discuss every case before radiation therapy begins. This includes more than 95% of cases prospectively. We meet 3 days a week and we have virtual rounds. This allows us to use consistent, agreed upon treatment volumes, doses, fractionation patterns, and the use of guidelines that are concordant with evidence-based treatment in our region, as well as coordination of complementary services like Gamma Knife, CyberKnife, and SBRT. To date, we've discussed over 7,000 cases prospectively since 2014, and what we found is that it changes the management in about 10 to 15% of our community radiotherapy practices. I believe this is a collaborative model that helps reduce some of the disparity seen within Eastern North Carolina. So some comments on academic community collaboration, because a lot of us here today are from academia, and this is a wonderful collaboration that benefits us all. As a very small community hospital, we lack many resources, like many, which is by definition a barrier to care. We're a 21 bed, we have no ICU, our focus is mainly on essential services. We're a so-called critical access hospital. But thanks to collaboration with academic facilities like ECU, UNC, Duke, Wake Forest, and a larger community hospital close by for us, Chesapeake in Virginia, as well as Atrium in Charlotte, smaller communities are then able to participate in tumor boards, perhaps virtually, which includes pathology and radiology services that aren't available locally. It might include medical oncology and radiation oncology expertise that we do not have locally, as well as thoracic surgeons, pulmonologists, and other levels of highly specialized care. It's my belief that collaboration is a huge leveling agent within a world of disparity. Notice the improvement in lung cancer mortality shown by the orange bar from 20 years ago to the present. We've dropped lung cancer mortality in North Carolina by about 35%. So the flip side of that is our survival is better. Notice how in our county, we've also improved. We started with a 25% higher mortality from lung cancer in our region, and it dropped more disproportionately relative to baseline. Most of this, I think, comes from a model of collaboration with multidisciplinary comprehensive care with experts like those today, and I think better access to care, technology, and resources that are regionally shared. So thanks for being part of a solution to improved outcomes in North Carolina.
Thank you, Dr. Shelton, for another excellent talk. And I think, very many important points. But a key one, I think, is that 80 to 90% of cancer care happens out in the community. It doesn't happen in tertiary care centers. And if we don't have strategies to make advances available out in the community where people live, then we're not going to be serving all that many people. So thank you very much. Has Dr. Oliver joined us?
It does not look like it.
Okay, so we're going to move on to Dr. Hagstrom from Levine Cancer Center as our next speaker.
Thank you. I've got a couple of screen juggling things here to do. Hope that's visible to all.
Yes, we can see it.
My name is Dan Hagstrom, and I'm sorry, I'm have to go back here. So I want to thank the LTI for having me here and to have the chance to talk to all that are involved online and otherwise. My name is Dan Hagstrom. I'm one of the medical oncologists, thoracic medical oncologist that works for the LCI in Charlotte. I have no disclosures. Still trying to make this work. All right. The objectives, we're going to review a recent publication for non-small cell. We're going to review recent publications for targeted therapy for non-small cell and a brief update for small cell lung cancer. So in brief, lung cancer advances in tissue testing and therapeutics continue to drive improvement in lung cancer outcomes. Historically dominated in the frontline setting by cytotoxic chemotherapy and immunotherapy, targeted therapy advances continue to provide new options for patients. Here we're going to review 3 of many important studies that have altered the practice over the last 12 to 24 months. First is going to be Checkmate 9LA. So in non-small cell lung cancer, this is a frontline study in which patients in a randomized phase 3 format were randomized 1-to-1 to compare 2 cycles of chemotherapy with combined nivolumab and ipilimumab, followed by immunotherapy maintenance compared to chemotherapy alone in patients that were treatment naive. So the chemotherapy, whether it be squamous or non-squamous, was dictated by histology with the option of maintenance pemetrexed for non-squamous cell patients. Again, all these were stage 4 non-small cell lung cancer patients with no sensitizing mutations. All stratifications of Pdl1 were allowed. So it was initially published in The Lancet in 2021, and the data was updated in ASCO last year as a 2-year update. And here is the median overall survival data, with it showing a median overall survival of 15.8 months versus 11.0 months, favoring the immunotherapy chemotherapy arm over chemotherapy, noticing that these curves separate relatively early and have a pretty significant tail or stay separated in further and longer patients that are out. The median duration of response for Pdl1 more than 1% was 11.8 months versus 5.6, whereas for Pdl1 less than 1%, which is a tough population, 17.5 months versus 4.3 months. And here is again a set of figures to kind of go through overall survival, PFS, and duration of response. And this, I didn't include all these because there's not time, but this is the exploratory analysis for patients that have Pdl1 of less than 1%. Again, median survival 17.7 versus 9.8 months, PFS 5.8 versus 4.9 months, and the overall response rate 42%, duration of response rate, 42% versus 26%. So the duration was 17.5 versus 4.3. All of these favoring the combination of immunotherapy and chemotherapy over chemotherapy alone, including an improvement in 2-year survival rates for non-squamous and squamous cell patient populations. From this hazard ratio plot, all subgroups benefited from this provision, excluding patients that are over the age of 75 and non-smokers. So again, across all the different stratifications, Pdl1 versus liver metastasis versus CNS metastasis, all patients had benefit if they received the combination immunotherapy and chemotherapy. Probably the most exciting thing from this study, 57% of patients experienced a treatment-related adverse event. That part's not very exciting, obviously, because those happened usually in the first 2 cycles of combination therapy, chemotherapy. Whereas 56% of the people who responded and had a treatment-related adverse event that had them discontinue therapy, they had a maintained response or stable disease for more than 1 year after treatment discontinuation. So I think in all of the medical oncologist practice, we see some of these patients, and it's starting to kind of see, we can see this in real time as patients who are discontinued and continue to respond. this figure highlights that. So for patients who discontinued all the components of the combination arm, the median overall survival was 27.5 months with a 2-year overall survival rate of 54%. And an ongoing response after 1 year of discontinuation of 56%. So pretty amazing. At one point, we were not able to control some of these adverse events that happened with immunotherapy. Now, the patients that are having those recognized and treated may actually do better than patients who don't experience this. So at 2 years, the overall survival with first-line therapy with immunotherapy and chemotherapy was durable versus chemotherapy across histologies. It was observed across key high-risk groups, including low Pdl1 expression, squamous histology, and patients with CNS metastasis. In a post-ad hoc analysis, discontinuation of the nivolumab and ipilimumab and chemotherapy arms due to treatment-related adverse events did not negatively impact long-term benefits seen in randomized patients. This is an updated result also that continues to support this type of approach in patients in the frontline setting. At the LCI, we have treatment guidelines that are tumor sections derive what is a preferred agent or preferred combination for any given histology. So you can see highlighted in red in this box, once this was published, it moved into our first line setting for patients with non-squamous and squamous. Second is targeted therapy quickly. So KRAS mutations account for 25 to 30% of all oncogenic driver mutations in non-small cell lung cancer, with KRAS G12C as the most common variant. Previously, it was only negative prognostically, and upwards of 30% of patients with KRAS G12 mutations have CNS metastasis at the time of diagnosis. Adagrasib is a covalent inhibitor of KRAS G12C. It's desirable therapeutic due to its long half-life, dose-dependent PK and CNS penetration. It's also an oral medication, which is much easier for patients. Crystal-1 and portions of the Crystal-1 data set were phase 2, in which patients all had failed prior systemic chemotherapy and possessed a KRAS G12C mutation. So this was a late-breaking publication that was released at ASCO this year that created a lot of buzz, and it was the phase 2 registration cohort in which all of the patients that were treated with adagrasib, as you can see in the study design at 600 milligrams BID, they were all non-small cell lung cancer patients. All had been previously treated with immunotherapy and chemotherapy, and CNS metastases were actually allowed in this study. So the median overall response rate was 42% with a disease control response rate of 89%. So that is a combination of partial responses and stable disease to achieve 89%. The median PFS was 6.5 months. The median overall survival of 12.6 months. So the first agent that came out for KRAS G12C mutant patients was sotorasib from the CodeBreak data. And from their phase 2 portion with non-small cell lung cancer patients that was published in New England Journal, very, very similar results with an overall response rate of 37%, a PFS of 6.8 months, overall survival of 12.5 months, and a disease control rate of 81%. So very similar. In both of these groups, 97% was in the adagrasib study and 99% for the sotorasib group. The majority of these were not grade 3 or 4. However, those were still quite high, 43%, 45%. The most common drug-related toxicities were not surprisingly diarrhea, nausea, LFT changes, and fatigue. Pneumonitis was seen very, very rarely. It was less than 2% in both studies. Adagrasib also showed activity. It was CNS metastasis for an intracranial disease control rate of 85%. Of note, in the sotorasib data set, that number was 88%. However, you can see as in this figure and graph of patients with target lesions, you can see in this waterfall plot that there are patients that had significant responses and cytoreduction of tumor lesions that had not been treated prior. So does have the ability to treat CNS metastasis.
Hey, Dan, I think we lost your slides.
Yeah, I was gonna say, maybe reshare your screen.
Hold on. Can you still hear me?
Yeah,
Yep, we hear you and see you. I think your sharing got kicked off.
Yes.
All right, let me try again here. Well, still looking, hold on. How about now? Can you see him now?
yes.
Yes.
Okay, sorry guys. I don't know what happened there, but let me see if I can make continue along these lines. So for patients with KRAS mutations, a new drug application was submitted for adagrasib, and it's under review for accelerated approval. There's a confirmatory study that's comparing docetaxel and salvage for patients. Here at the LCI, we actually are running a phase 1 study for patients who have not been challenged with targeted agents yet. That's an Amgen protocol that's using sotorasib in combinations with immunotherapy and other molecular agents. So the KRAS field is expanding relatively rapidly. All right, let's talk briefly about small cell, if I can keep the slides from going away. Small cell lung cancer represents 15% of lung cancers and is almost exclusively seen in smokers. Despite initial robust responses, historic median survivals for extensive stage have historically ranged from 8 to 10 months with a 5-year survival rate of only 1 to 3%. The first improvement in survival in nearly 3 decades was witnessed systemically for extensive stage patients with the publication of Power 133. So this was initially published in 2018, and the survival and Pdl1 data was updated in 2021. There were 403 patients that were randomized to get carboplatin, etoposide, and atezolizumab compared to carboplatin and etoposide alone. And the immunotherapy patients received maintenance atezolizumab for 6 months. It was updated last March and follow-up at 23 months with a median overall survival of 12.3 months to 10.3 months, favoring the immunotherapy containing arm, PFS of 5.2 versus 4.3 months. Very similar toxicity between the two arms. And neither Pdl1 nor circulating tumor DNA mutational burden had any role in predicting response. This is very similar to the Caspian data set, which was published in 2009. Only difference being is that in Caspian, durvalumab was the immunotherapy agent that was utilized. In its initial offering, it did show an improvement in overall survival, 13.0 versus 10.3 months. Same format, same setup. There were 537 patients that were randomized, and patients got chemotherapy or chemotherapy with durvalumab maintenance. And the overall survival that was assigned to the 4 to 6 cycles was 12.9 months versus 10.5 months when they updated the data set most recently. Landmark PFS at 2 years was 11% with the durvalumab arm versus 2.9 months. 2.9%. The objective response rate was 68% versus 58%. And those who responded to the durvalumab arm, some of their responses were quite durable by comparison. So very good result. Why am I reviewing these old things? Well, at ASCO this year, there was an attempt at adding additional medications to the triplicate that I spoke about. So Skyscraper 2 was a randomized phase 3 trial of tiragolumab versus placebo in patients that were getting atezo versus carboplatin first-line therapy. This medication is a human anti-TIGIT monoclonal antibody that's hypothesized to synergize with other immunotherapies such as Pdl1 inhibitors and atezolizumab. And treated and untreated brain metastases were allowed in this study. So you can see how these patients were randomized 1-to-1. The TIGIT antibody was given in this segment versus placebo and the others. There's no crossover, and both arms ended up getting atezolizumab maintenance. Well, this is a small slide in terms of presentation, and this was a negative study. As you can see in the PFS and overall survival on the data sets, 5.1 versus 5.4 months, not statistically significant, favoring the placebo arm, and 13.1 months versus 12.9 months in the overall survival, and that's favoring actually the study arm. Neither one of those is clinically significant. This was a negative study, but it also is really important because the information and data in blue is further confirmation that the addition of atezolizumab to chemotherapy can extend small cell lung cancer patients' survival. As you can see, 12.9 months mirrors very much closely to that seen in the Caspian data set as well as IMpower 133. So it certainly provides some support even in a negative study. In our guidelines, here is how we've adopted and kind of moved into this space for our providers in our system to use in the first-line setting. We also have a frontline study that's incorporating a SNF and 11 inhibitor, which is a send-out test for patients if they do possess it. It's known by the time the atezolizumab starts. I would also, in the coming months, anticipate the results of NRG LU005, another study that we ran here at the LCI, in which patients were with limited stage were getting checkpoint inhibition as well. So finally, for the conclusions, and frontline chemotherapy and dual agent immunotherapies has significant activity in high-risk, standardly refractory subgroups for non-small cell lung cancer patients. The options and potential for targeting KRAS mutations is expanding, with published data from Crystal 1 supporting fast-track approval for adagrasib. And although to date, additional agents have yet to improve upon the benefits that we have seen with chemotherapy and immunotherapy in extensive stage patients, it remains the standard of care in the frontline setting based on the Caspian and IMpower 133 data sets. This photo, I went to France this summer and found this cigarette box on the ground. I thought that was quite interesting how they depicted this for people not to smoke as an example of why you should not do that. So anyhow, and that's all I have.
Dr. Hestrom, thank you very much. That was a great talk, and I think it really illustrates how we're starting to be able to take advances of immune therapy into areas where we didn't have a lot of success, like in the Pdl1 negative tumors. KRAS, which is the most common oncogenic driver in lung cancer, starting to be able to offer molecular therapy within that biomarker group, and an extensive stage small cell, which had not seen any advances in 30 years. You know, now that we have immune therapy, we do have people that are long-term survivors. So we're getting to the point where pretty much for all groups in advanced lung cancer, almost all patients, we can offer some hope of a prolonged survival, and that's really been a big advance.
I would agree.
So thank you very much. And now we'll be moving on to Dr. Patel.
Well, thank you for having me today. I'm a thoracic medical oncologist at the University of North Carolina in Chapel Hill. And to build a little bit on Dr. Hagstrom's talk, I'll be speaking about comprehensive biomarker testing in lung cancer and how we can hopefully use this to select the appropriate therapy for our patients and identify patients for some of these novel therapies that are now both becoming available as FDA-approved drugs as well as through clinical trials. So what are biomarkers that we're interested in looking at in lung cancer? Well, they fall into two broad categories. Some are genetic changes that are present in the tumor that can help to identify patients that may be eligible for targeted therapies. The other broad class of biomarkers are those that focus more on the tumor microenvironment that give us an idea of how patients may respond to checkpoint blockade. I'll then review approaches to biomarker testing, whether they be based on a tumor biopsy or a liquid biopsy, and review what should be tested in terms of comprehensive testing. So to walk us through, I wanted to go through a patient case. This is a 47-year-old gentleman with a 5-pack-year smoking history, initially presented to the primary care with a cough for several months, had a chest x-ray and was found to have a lung mass, and eventually through workup, including chest CT and PET scans, unfortunately found to have metastatic disease. They have a biopsy that shows an adenocarcinoma. So to decide on treating this patient, what additional information do we need as medical oncologists? So for a long time, we used to rely just on the histology of the tumor, broadly categorizing lung cancer as non-small cell, then subcategorizing into adenocarcinoma and squamous cancers broadly, or small cell lung cancer. But we've learned from genetic and microenvironmental profiling of these cancers that really lung cancer is quite a diverse disease, and each patient's cancer is very unique, both at a genetic level as well as in terms of the microenvironment of cancer. And this has been through large-scale efforts such as the Cancer Genome Atlas that have sequenced a number of lung cancers, as well as sequencing cancers that develop in the metastatic setting. And what this has shown is at the genetic level, lung cancer is quite diverse, and particularly focusing on the subset of lung cancer that falls into the non-squamous, non-small cell lung category. This pie chart depicts the broad number of genetic changes that we can find in these tumors, and specifically focuses on how these genetic changes can identify patients that may be eligible for a targeted therapy. And I'll talk a little bit about some of the most recent approvals of targeted therapy, just as Dr. Hagstrom discussed, KRAS mutations, which were largely considered undruggable for a long time. But I think this chart illustrates nicely that understanding the underlying genetic makeup of cancer is really important in being able to identify the most appropriate therapy now that we have so many different agents that are approved as targeted therapies for patients. So how do we identify these biomarkers? So one approach is to do tissue-based testing. And that can involve a number of different methods, including immunohistochemistry, which we'll talk about for Pdl1 testing, and other methods to look at the genetic changes that are present in the tumor. So this can include fluorescent in situ hybridization or FISH testing, which looks for chromosomal changes. Historically, we used approach to sequencing the tumor, which was polymerase chain reaction or PCR testing, which really allowed analysis of single genes. And what has become much more commonly used for broader genomic profiling, given the number of targets that we're now looking at, which is next generation sequencing, either of DNA or RNA that's isolated from the tumor. So what exactly is next generation sequencing, and what information do we get from that? So this is a different approach to analyzing the genetic changes in the cancer, in that it's a higher throughput sequencing method, which in contrast to older methods which looked at single genes, can concurrently analyze a number of different genes. And this is important, particularly as the number of targeted agents that we have in the frontline setting has expanded pretty significantly in the past few years. So the advantage of this method is that it can actually be much more comprehensive as an initial test over single gene or hotspot sequencing, because you're looking at the entire coding sequence of several genes at the same time. Along with that increased coverage and analysis, there are some complexities to understanding next generation sequencing, which often has to be done in specialized labs with interpretation by molecular pathologists or bioinformaticians, which can be difficult for interpretation in some cases. This next generation sequencing approach can be performed on tissue specimens, which has been the most classical way to look at it. But now we also know that these genetic changes can be identified through liquid biopsies or by analyzing blood-based specimens. So tissue specimens rely on using a tissue sample from a patient. But as we are increasingly able to get tissue with smaller methods, such as fine needle aspiration or bronchoscopic procedures, we're learning that it may often be difficult to get enough material to do comprehensive testing on patients. So liquid biopsies or circulating tumor DNA analyses offers a often complementary method to get complete biomarker testing done for patients. So this is a non-invasive method that can be performed on peripheral blood collected from a patient. And circulating tumor DNA has been the most extensively studied component of a liquid biopsy. But there are a number of other measures of liquid biopsy, such as circulating tumor cells and RNA, that are being looked at as biomarkers. The ctDNA refers to the tumor-related fraction. And lung cancer was actually at the forefront of this, and that the COBAS EGFR test was one of the first circulating tumor assays that was approved as a companion diagnostic. Now these liquid biopsies actually incorporate some of the next generation sequencing methods that we were discussing before, where a broader number of genes can be analyzed, offering more comprehensive testing for patients. But it's important to understand some of the limitations of these approaches as we work to interpret the data from liquid biopsies. So while these can be very helpful in patients that have limited tissue specimens for doing genetic analysis, it's important to remember that you can have false negatives. So not identifying anything on a liquid biopsy doesn't mean that it may not be present. It may be just a function of the test. For patients with a lower tumor burden or limited extrathoracic sites of disease, may have less circulating tumor DNA that can be collected from a plasma specimen. It's also important to look at the specific genetic changes that are identified through this method and interpret them in the context of whether those changes are ones that have been seen in lung cancer and are known to be actionable. Because these circulating methods can also pick up genetic changes that may not be directly derived from the patient's tumor, but from processes such as clonal hematopoiesis, which we see in patients with increasing age that don't reflect the lung cancer itself, but underlying bone marrow changes. They can also be more limited because of the smaller panel size and detecting novel fusions that can be difficult to identify in DNA-based only analysis. And these liquid methods cannot give us information about the histology of the tumor, so they can't really replace histologic analysis in initial diagnosis or changes that may occur, particularly when patients are on targeted therapy such as small cell transformation. But they have provided a very important adjunct approach to getting comprehensive testing for patients. And the International Association for the Study of Lung Cancer provided some guideline recommendations on how to use these approaches in patients that are diagnosed with advanced or metastatic non-small cell lung cancer. There's a number of different approaches that can be used. One is a more sequential approach where patients have a tissue biopsy that appears adequate by pathologic analysis for genomic profiling, and they have their tissue analyzed first. A liquid approach may be used if there's inadequate coverage of areas that were known to be important for lung cancer treatment selection, or in patients that are on targeted therapies and then have progression of their disease. A complementary approach could be used in those patients where it's uncertain at the time of biopsy whether there is sufficient material to perform comprehensive testing, and that both concurrent tissue and liquid-based approaches can be used to identify all the genomic markers that are present and not delay identifying some of those markers. And in contrast, in patients that may have tissue that's unavailable for genomic profiling, they may adopt a plasma first approach where the plasma is tested, and if a genomic biomarker that's actionable in lung cancer is identified, then another biopsy may be avoided for patients to identify these genomic changes. So it really depends a little on an individual patient circumstance, but a combination of tissue-based profiling and liquid-based profiling based on the individual patient circumstance and approach can be very helpful in getting comprehensive testing for patients to select for targeted therapies. The other big class of therapies that we now use for patients with advanced lung cancer is immune checkpoint blockade. And here, the main biomarker that's been clinically useful is to look at Pdl1 expression. And this has been done predominantly by immunohistochemistry, which is looking for the expression of this protein on the surface, either of immune cells or tumor cells. With lung cancer, the expression of Pdl1 on tumor cells has been one of the more widely used biomarkers. And this is a bit of an indirect marker of the likelihood of response to immune therapy. So patients with higher Pdl1 expression on their tumor cells more likely to respond to a single agent immune checkpoint blockade, and those with negative or lower expression may be more candidates for combination therapies. Pdl1 expression also is a bit of a tricky biomarker in the sense that because it is relying on immunohistochemistry and protein staining, it can be variable. So at different places in a tumor specimen, if you biopsy, you may see different levels of expression, but it's one of the most robust biomarkers we have for selecting patients for immunotherapy. So going back to our patient case, they have biomarker testing performed on their specimen and are found by immunohistochemistry to have a Pdl1 expression of 80% on tumor cells. But the genomic profiling on the tumor also identifies a KIF5B RET fusion. So this are two somewhat conflicting biomarkers. So what we've learned is that in patients that are identified to have these targetable mutations, those tend to trump the Pdl1 expression. So it's important to wait both for looking at your immunohistochemistry for Pdl1 as well as comprehensive biomarker testing to look at genomic changes before selecting a therapy for a patient, because those patients that have a genomic biomarker identified often benefit from that targeted therapy more so than immunotherapy if the Pdl1 expression is high. And it's also important because treatment sequencing can be really relevant in these circumstances. Patients that have these genomic changes, if they're started on immune therapy first and they're then identified to have a targetable alteration, giving those targeted therapies after immune therapy has been shown in the case of EGFR mutations and ALK fusions to have increased side effects. So it's important to kind of have both pieces of information. So once we have this comprehensive biomarker testing, as the graph I'd shown earlier alluded to, this has been really helpful in selecting patients for the appropriate targeted therapies that can be used in the frontline setting. So using our patient case as an example, I wanted to go through a little bit of data on some of the most recent approvals of targeted therapies that we now have for lung cancer patients, which have really expanded quite significantly in the past few years. So RET fusions is one of these that we have recently had approvals for 2 agents. RET is a receptor tyrosine kinase that can be activated by both fusions or point mutations. In lung cancer, we see it most commonly activated by fusions with other partners such as KIF5B, and this is present in about 2% of lung cancer cases, more commonly seen in other cancers such as papillary thyroid cancer and a rare smattering of other diseases. And we've seen 2 studies published over the past few years that have led to approvals of targeted drugs for these RET fusions. The Libretto 001 study was a phase 1/2 of selpercatinib, which is a RET kinase inhibitor. And this waterfall plot here shows the activity of this agent in patients with lung cancer, either those that had been previously treated with chemotherapy or were treatment naive. And what you can see from the waterfall plot is something that we've come to become accustomed to with these targeted therapies. Really quite significant deep responses in patients, so high response rates both in previously treated as well as treatment naive, as well as seeing intracranial activities with these drugs in contrast to standard chemotherapy. So knowing this information really important in selecting therapy for our patients. Similarly, the ARROW study looked at another RET tyrosine kinase inhibitor, pralsetinib. This was a phase 1/2 study that included patients with RET fusion positive non-small cell lung cancer, as well as medullary thyroid and other RET fusion positive cancers. And again, you can see with the waterfall plots, high response rates in these patients, both treatment naive as well as previously treated with platinum agents and intracranial activity. So this provides a good treatment option for a patient with this fusion event. So this chart summarizes the biomarkers that are particularly relevant in selecting therapy in the frontline setting for patients with advanced non-small cell lung cancer. So EGFR being the prototypical example of a targeted therapy for patients. ALK, ROS1, BRAF mutations, Imrt, less common, RET fusions as we discussed, and MET exon 14 skipping mutations. And then I wanted to highlight a couple of other areas where targeted agents have moved into the treatment space in the second line setting, which is for looking at patients that have more uncommon EGFR mutations, such as these exon 20 insertions, for which amivantamab and mobocertinib were recently approved, briefly touch on sotorasib since it was discussed earlier, which is approved in the second-line setting with encouraging data for adagrasib as well. And then just recently the approval of an antibody drug conjugate for HER2 exon mutations. So just to breeze through this part really quickly, since we already heard a nice summary of KRAS targeting. So KRAS long considered one of the undruggable genomic changes in lung cancer until the recent development of several irreversible KRAS G12C specific inhibitors. So the drugs really are specific for this isoform of KRAS that bind in the inactive GDP pound state and kind of block the KRAS mutation in that position. So briefly summarizing, as we heard before, the phase 2 study, CodeBreak, which looked at sotorasib, showing encouraging overall response rates and progression-free survival in a second-line setting. And then more recently, the data published from the Crystal study of adagrasib, which is another KRAS G12C specific inhibitor, showing really similar response rates, progression-free survival, and disease control rates. So offering another treatment option for patients post-progression for those with specifically these KRAS G12C mutations. Now, we've learned from these broad sequencing approaches that while EGFR mutations such as the L858R and exon 19 changes are the most common alterations we see in lung cancer, there are a number of rare EGFR mutations that have been difficult to target with the previously approved EGFR TKIs. And these include these exon 20 insertion mutations, which haven't really responded to the previous generations of tyrosine kinase inhibitors. And we now have 2 agents that have been approved in previously treated patients that have these EGFR exon 20 insertions. One is an antibody, amivantamab, which targets both EGFR and METs. It's a bispecific antibody. This medication is currently given as an IV formulation, but there are subcutaneous dosing approaches that are being explored. In the second-line setting, they saw response rates of about 40% with a duration of response of 11 months. It's very encouraging. And then mobocertinib is another EGFR tyrosine kinase inhibitor specifically designed to work for these exon 20 insertions. Here they're seeing response rates in the order of 28% with duration of response of around 17.5 months. So these both options for patients post-progression on chemotherapy. Then finally, just briefly to touch on one of the most recent approvals of a targeted agent in lung cancer, which was based off of the DESTINY-Lung01 study for looking at trastuzumab deruxtecan. So HER2 mutations, which are often insertion mutations, have also been difficult to target with tyrosine kinase inhibitors in lung cancer. But this antibody drug conjugate, trastuzumab deruxtecan, which is HER2 targeted to a topoisomerase drug, has been looked at in patients with HER2 mutations. You can see here the waterfall plot of this study that was published earlier this year in the New England Journal, showing activity for this antibody drug conjugate across a number of different types of HER2 mutations, which is interesting, specifically HER2 mutations, not looking at amplification in contrast to breast cancer. And summarizing here, the response rates in the DESTINY-Lung01 study, they saw responses on the order of over 50%, and stable disease in a number of other patients with a median duration of response of a little over 9 months. So based off of another study, which looked at a slightly lower dosing, this agent has also recently been approved in the past few weeks as an option in the second-line setting for patients with these HER2 exon 20 mutations. So to summarize, biomarker testing is really critical in therapy selection for lung cancer. I focused here really on the advanced setting, but as both targeted therapies and immune therapies move into the earlier stage setting, testing for these is important for neoadjuvant therapy selection as well as adjuvant therapy selection in the case of osimertinib. And so testing for EGFR, ALK, ROS1, BRAF, NTRK, and MET exon 14 and RET should really be part of the standard workup for all patients with advanced non-squamous cancer at the time of diagnosis, given the availability of highly effective targeted therapies. And that can be done through tissue-based testing, which has previously really been our standard of care, or a complementary approach such as liquid biopsy if adequate tissue is not available. And then KRAS, G12C alterations, EGFR exon 20 insertions, and HER2 mutations can now be targeted at the time of progression. So they can be important to know after patients have progressed on previous chemotherapy. And so given the number of alterations that we can now target in various settings, really comprehensive testing that incorporates next generation sequencing is the most efficient in terms of identifying these alterations with limited tissue specimens. And then for Pdl1 testing, immunohistochemistry is the main approach and is used for treatment selection for immune checkpoint blockade, both in the advanced setting as well as for stratifying patients that may be most likely to benefit in the neoadjuvant or adjuvant setting for immunotherapy, which is now moving into the clinic more as well.
Thank you, Dr. Patel. That was great. 20 years ago, all lung cancer was the same. And to have these advances where we have all these subsets of cancer where we can specifically identify what's driving the cancer and have some specific therapy for it that gives us better treatment with less toxicity and better outcomes has just been a huge advance. So last but not least is Dr. Ruiz from Wake Forest. Thank you for being our last speaker, Dr. Ruiz.
Neil, so I'm going to be moderating our discussion today, but I think we're missing a surgeon. And Neil, I'm not ready. I'm not sure if you're ready to present or if you would like me to present on behalf of our surgeon.
Well, I think that's right. Our surgeon has been called off to surgery, and I think that we're at 7:30, so I think we may have a lot of questions, and then we were also going to interact with the exhibitors. So I think we'll just go ahead and proceed to the panel.
That sounds good. That sounds good. So what I'll do is I'm going to man the chat, and I'm supposed to be moderating the session. So what I will do is I will look for anyone in the chat, but I'll go ahead and start with a question, and it's going to go to Dr. Mehta, because you made the point of NLST, and we're almost at a decade. Why is screening only 8%?
That's a great question, and I think one that puzzles even me. I think it's multifactorial, and I think a lot of us providers, not just with screening for lung cancer, but treatment, and we've heard community-based care. I think there is a socioeconomic discrepancy. I don't think we do a great job screening communities that aren't that are lower socioeconomic status. I think it's education. Problem with lung cancer screening is it is 10 years old, but I think we are just catching up in terms of educating our primary care providers, pulmonary, some of the key providers that these patients should be hearing about lung cancer screening. And it's these venues that I'm hoping that would provide some of this education. But I think there's a big knowledge gap, and there's still a stigmata with smoking. And so I get a lot of those myths that we discussed at the end of my thing that, oh, I quit smoking, I can't get cancer anymore. Or so it's breaking through some of those myths. Even providers have misconceptions. So I think there's a big knowledge gap, and hopefully people like our group here today will continue to spread the word and information regarding screening. The good news is we're improving.
Very good. Thank you. Any other comments on that? I know that being in North Carolina and seeing that our population is most impacted with lung cancer, especially the rural population, it's just hard to accept that, and I know we've been talking about this for a while, and we have great advocacy groups, but at some point the accountability, if this was breast cancer, there would be people at the White House marching, right? I mean, this is just, I think there's a lot of elements that you've mentioned that need to be tackled, but I think certainly it's an area that we all need to really elevate because ultimately that's what's going to save people.
Dr. Mehdi, if I can just intrude for a minute, do you think any of it has to do with the stigma around lung cancer and everyone, including healthcare providers, saying, well, these people did it to themselves, so why should we screen them? I mean, my parents both smoked. They were good people.
Right. That's a huge part of it. That's a huge part of the stigma of lung cancer screening. And I think everybody who's ever been involved in lung cancer has felt it at some level in terms of funding, grant money, research funding. I think lung cancer has felt it all along, where you fall short of what you need because of that stigma of you deserve it. It's unfortunate, and I think we're getting better. I'd like to think we're getting better, but that is a big part of it. Yeah.
Hey, Heron, Mark Yaffe, can you hear me?
Hey, yeah. Hey, Mark.
So I think one slide you said the median age or the age of onset for the Black population was 50 versus 63 for whites. Shouldn't we move it? Was it 59?
Yeah, 59.
Okay. Then
it was lower. It was lower than 63. There was a discrepancy, but yeah, it was around 59.
Okay. So I was going to say with 50, then we should move the age, kind of like in prostate cancer where it's an earlier onset for blacks versus white. We should move the age lower, but it's 59, then 50 works.
To tell you the truth, that shift from 55 to 50 now, because the new guidelines cover up to as young as 50 now, that will help. That's actually that. I didn't spend too much. I didn't want to belabor it, but that reduction in age is to help narrow that gap, so we can broadly cover more African American populations and women. Those are the two big benefits from moving it from 55 to 50.
All right. So let me move over to the chat now. And so the first question I think is from you, Mark. It's you indicated any role for Pdl1 or PD1 and NGS in small cell. I guess this one's I would imagine, is this for our Dr. Hagstrom? You want to tackle this one?
Sure. Short answer is no. There's not been a study to date that has shown that PD1 or Pdl1 expression plays any role in choosing agents or predicting response in small cell. Now, that being said, from the data from Caspian and IMpower 133 and the NRG study, probably for limited stage, there is a role for immunotherapy regardless of the PD-L1. But in terms of that, I don't believe there's a good reason to test for it because it doesn't really predict response.
Yeah, agreed. And we haven't unfortunately found genomic biomarkers for patients with small cell lung cancer to date, at least as part of standard of care. There are, research practices that are looking at gene expression changes that may categorize different types of small cell lung cancer, but that's more in the research realm at this point.
So neither one of you are testing your small cell patients for NGS or PDL in standard of care?
No.
Okay. Good, I would agree.
All right, and since so Dr. Hagstrom, one question here is how do you approach patients now with immunotherapy being on almost every other commercial and them not wanting chemotherapy or trying to avoid it? What's your approach to kind of an IO only versus chemo IO approach for those patients, especially those who don't want chemo?
Well, in a lot of the studies that are coming out now, if there are patients that refuse chemotherapy, they can still be included. Now, that being said, for data that we are presenting from Checkmate 9LA and others, we're seeing there still is a role for chemotherapy in combination with IO, and I think that we're going to see more of that as opposed to IO-only regimens. Obviously, for people with high Pdl1s, without any driver mutations, single agent IO is still attractive, and there's certainly low-level responses that are seen in Pdl1 negative patients or low patients, but that just has to be something that you talk with the patient about what their goals are and kind of how they want to approach an incurable illness and what their willingness to risk being sick is. So I think you have to guide with data, though. If somebody comes to your office and asks for advice and says, I'd like to live longer, you're going to have to give them what is there as a part of the choice to choose. So,
yeah. So in cases, then what's your cutoff then? In cases where you have a PDL1 of, I don't know, say 30%, and the patient's kind of leaning towards not getting chemo, what do you tell them?
Well, I think you can justify that based on some of the keynote data, as well as some of the checkmate data for patients that are in this gray area. The nice thing about the LCI here in Charlotte is that we've got phase 1 clinical trials for patients with a novel immunotherapy compound in which they get that plus immunotherapy for PDL1s of 1% to 49%. So we've got an option for that for the patients if they're adamant about not getting chemotherapy. And I think we're going to see more studies kind of expound in that gray space. So I think the really exciting thing from the checkmate data that I presented is that historically when you see patients with PDL1 0, your stomach drops for them because you know what you're looking at in terms of a potential response. And now you can see that these folks with 2 cycles of chemotherapy and maintenance immunotherapy can do quite well. So that is going to change some of the paradigm for how patients with negative results are treated, or it should.
Dr. Patel or Neil, any other comments on that?
No, I agree. I think that there's some pretty strong data now that in the PDL1 negative group, that there's evidence that inhibiting CTLA4 may be enough to kickstart the immune response.
Yeah, I agree. And I think the individual patient decision and those sort of intermediate cases, depending on, the rapidity of their disease burden and symptoms, and how quickly you need a response can be helpful.
Thank you. Along the lines, this is going to be for you, Dr. Patel. There's in the chat, there's a comment about biomarker testing. This is kind of another sore topic for lung cancer. We don't do it well enough, I think. But one question is, Dr. Patel, any data on benefits of liquid biopsy in the screening process?
So at this point, not in terms of standard of care for looking at liquid biomarkers for screening, but I think really it is an active area of investigation, both in terms of sort of risk stratifying nodules, that there's been investigations, and then there are a number of studies that are launching, basically looking at blood concurrently with traditional lung cancer screening approaches like low-dose CT and seeing how well those blood-based assays perform. So I think it's more in the research setting, but maybe something that we see in the future as either an adjunct to low-dose screening to help, better risk stratified patients that need biopsies or further imaging more rapidly.
Now, along those lines, in terms of, diagnosis of lung cancer and standard of care biomarker testing, one of the questions points to why not do both, do blood and do liquid at the same time to try to maximize your yield and find all those wonderful targets that you discussed with us?
Yeah, no, it's a good question. And certainly in some places that is the approach that's being taken. I'd be curious to hear from some of our other oncologists what approach they're using. I think, cost is certainly a concern to patients in particular, because oftentimes it may be using 2 different platforms to do the testing, depending on your local practice. But certainly there have been studies that have been done showing that doing both approaches maximizes the frequency of alterations that can be identified. My sense is that if you find your initial driver, that is most useful in selecting the first therapy, and then doing additional approaches like liquid biopsy if you don't find something is useful, if you don't find that initial driver. But certainly an approach that places are taking to get results more quickly, including you're not even just waiting till the pathology has been confirmed in terms of a lung cancer diagnosis, but even sending the liquid at the time of initial bronchoscopy or something like that. So these results are available to an oncologist at the time of their initial consultation.
Okay, so there's one. Let me just do one. Jenny, do I have a time for one more question? Okay, one more question. So this, I think, is for our medical oncologists. Do we have patients where we have not stopped immunotherapy? I would imagine after the 2-year in the metastatic setting. Thoughts there?
It's a challenging conversation, and I've had a couple of patients, and I'm taking my patients off. I had a couple of folks this past year that kind of, when this data started to become more prevalent, had been on for 2.5, 3 years, and it just requires you to go through what you know and what you didn't know when you started the patient, and what is safe. Giving these medicines indefinitely, we don't know how safe that is. Whereas given the evolving data, that even some of the things I presented today, if you have a good response, or what if you were fortunate enough to have a treatment-related adverse event that was caught quickly and treated, you may not need the medicine for quite some time. So I am personally taking my patients off, and after the 2-year mark, if they've exceeded it, unless they have a reason or protest against it, and then when they